You've almost certainly heard of GERD, or gastro-oesophageal reflux disease. It affects millions and millions of people. So you'd think diagnosing it would be a piece of cake, right? Well, for years, it's actually been this incredibly frustrating puzzle for both doctors and patients. But that's all starting to change. A new international agreement called Lyon 2.0 is basically rewriting the entire rulebook. And today, we're going to break down exactly what that means for everyone. So here's how we're going to tackle this. First, we'll look at why it's been such a puzzle to diagnose. Then we'll get into the new rulebook, Lyon 2.0. We'll cover what now counts as solid, conclusive evidence and how that evidence leads to two very different diagnostic paths. And finally, we'll wrap up with why this new playbook is such a big deal. All right, let's dive right in. The puzzle itself. Why has GERD, this super common condition, been so darn confusing for so long? Well, it pretty much all boils down to the symptoms. This is the million-dollar question, isn't it? It's the one that has caused so much confusion. See, for a long time, diagnosing GERD was often just a conversation about how you felt. But as we're about to see, just relying on symptoms, well, that can be a fast track to getting the diagnosis wrong. And this is where the picture gets really muddy. Sure, you've got the classic symptoms everyone knows, but here's the kicker. Even if you feel better on medication, that's not proof. Get this. The placebo effect in some studies is as high as 25%. That means 1 out of every 4 people might feel better on a pill that does absolutely nothing. Then you've got this whole other bucket of atypical symptoms, which the evidence now shows often have very little to do with GERD at all. It's just a perfect storm for confusion. So, to cut through all this fog, 21 international experts got together to update the official guidelines. And what they came up with is the Lyon Consensus 2.0. And it introduces a really powerful new concept. They're calling it actionable GERD, and this is a game changer. It completely shifts the focus. It's not just about I have heartburn anymore. Now it's about having objective, conclusive proof from actual testing. The new thinking is simple. We need to prove GERD exists before we even think about putting someone on lifelong medication or recommending surgery. The bar for evidence just got a whole lot higher. So that leads to the obvious question, right? What does this new rule book actually consider to be conclusive evidence? What's the new gold standard for a diagnosis? Okay, this right here is one of the single biggest changes. During an endoscopy, doctors look for inflammation from acid damage. A moderate level of this, called LA grade B, used to be considered kind of borderline, inconclusive. Not anymore. Under Lyon 2.0, if a doctor sees LA grade B, that's it. It's conclusive evidence of GERD. Full stop. Diagnosis confirmed. And it's not just that grade B. The new rules are crystal clear. If an endoscopy shows more severe inflammation, a condition called Barrett's esophagus, or a peptic stricture, which is a narrowing from all that acid damage, any of those is definitive proof. But what if the endoscopy looks totally normal? Well, the next step is reflux monitoring, where a tiny probe actually measures how much time acid is spending where it shouldn't be, in your esophagus. And under Lyon 2.0, there's a new magic number. If your acid exposure time, or AET, is greater than 6% over a day, that's it. That's a conclusive diagnosis. The new guidelines also bring some much-needed order to that whole symptom puzzle we talked about. They officially sort symptoms into buckets, confirming that things like heartburn are highly likely to be GERD. But just as importantly, they classify things like hoarseness or that lump in your throat feeling as having a low likelihood. This is huge for helping doctors avoid chasing the wrong leads. So with all these new ways to find evidence, how does it all fit together? Well, Lyon 2.0 creates 2 very clear, distinct pathways for testing. And which path you go down all depends on the answer to one simple question. And that's the question. Does this person already have conclusive, slam-dunk evidence of GERD from past testing? Because depending on whether the answer is yes or no, the entire reason for doing the testing changes. This is just brilliant. Here are the 2 paths. Path 1 is for what they call unproven GERD. If there's no solid proof yet, the goal is simple. Find it or rule it out. And to do that, you have to do the testing off any acid-blocking medication to see what's really going on. But path 2 is for proven GERD, someone who's already been diagnosed but is still having symptoms. Here, the goal is totally different. It's to figure out why the treatment isn't working, so the testing is done on their medication. And what's so smart about this is that the goalposts actually move depending on which path you're on. For those unproven cases off medication, you're looking for that acid exposure time to be over 6%. But for proven cases on medication, the bar is different. You need an AET over 4% plus more than 80 separate reflux episodes. This helps doctors zero in on who has truly treatment-resistant GERD. Okay, so we've gotten into the technical details. Let's zoom back out. What's the bottom line? Why should any of this matter to you? What's the real-world impact of all this? At the end of the day, it all comes down to clarity and confidence. This new rulebook means way less guesswork for doctors and a lot fewer wrong turns for patients. It gives doctors a clear, evidence-based roadmap, which gives them the confidence they need to recommend major treatments like surgery. And that whole two-path strategy means your care is tailored specifically to your unique medical history. And that right there is the ultimate goal. You don't have to take my word for it. The authors of the consensus summed it up perfectly themselves. It is all about moving away from a one-size-fits-all approach and towards a personalized strategy that looks at your specific case.
It really leaves you with a fascinating thought, doesn't it? By finally solving this decades-old diagnosis puzzle, Lyon 2.0 hasn't just clarified the present, it might have just kicked open the door to a future where treatment for reflux is more precise, more effective, and more personalized than we ever thought possible.